Broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening, regardless of what part of the world you're coming from, we welcome you. Thank you for joining the webinar on countering stigmatization in the humanitarian response to COVID-19. Just a few brief opening remarks before we, and housekeeping before we kick off. We request all participants to ensure that they've muted themselves. This webinar is being recorded, and we want to make sure that we minimize background noise. The recording from this webinar will be posted on the Interaction website for those who wish to view it again or share it with your colleagues. My name is Jenny McAvoy. I'm Director of Protection here at Interaction. I'll be moderating today's discussion. We have 4 expert panelists with us today who I will introduce in a moment. Each panelist will provide some opening remarks and observations, and then we'll explore their experience and perspectives a bit more through a conversation. Once we have heard from all 4 panelists, we will then invite all participants to submit their questions and their comments for the panelists. Do use the question box that you'll see probably on the right side of your screen for this purpose. And with that, I think we can get started. First, just to share our objectives for this discussion. Livia, can you move to the next slide, please? We at Interaction have been looking at the challenge of stigma as a protection concern in humanitarian crises. And we're building up to take a closer look at how stigma was playing out in contexts like Iraq, in Cox's Bazar, in Myanmar, and so on, when the COVID crisis hit. And we realized a couple of things. Number one, that pre-existing stigma was going to play quite a prominent role in how COVID affected vulnerable populations, but also recognizing that COVID itself and health pandemics in general bring a lot of new patterns of stigmatization and new concerns. So we want to spend some time in our discussion today to identify some challenges in the context of COVID and some potential strategies to counter and minimize stigma and its effects. And we want to deepen our understanding of the dynamics of stigmatization in humanitarian crises, and look at what kind of capacities we need in the humanitarian community in order to be more cognizant of and more effective in addressing stigma in humanitarian crises. So with that, I'm going to introduce you to our first panelist, Dr. Goleen Samari, joining us from Columbia University. Goleen is a public health demographer and assistant professor in the Heilbronn Department of Population and Family Health, the program on forced migration and health, and the program on global health and justice and governance at Columbia Mailman School of Public Health. Her research focuses on social inequities on the basis of migration, gender, race, religion, shape population health, particularly paying attention to populations in or from the Middle East and North Africa. Goleen, can I turn it over to you and invite you to give us your initial observations and remarks?
Yes, thank you for the introduction, Jenny. Good morning, afternoon, evening, everybody. Thank you for joining us. So we've seen a lot of headlines that migrants and refugees are the human cost of the coronavirus pandemic. But I want to unpack a little bit what that means. So I think it points to the vast impact of stigma in the pandemic, but I also think that in order to understand these conditions, it's good to unpack for this webinar what stigma is. So in the population health literature, stigma is really defined as the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination in a context in which power is exercised. So historically, we've seen stigma with HIV, mental illness, sexual preference, and numerous other things, including infectious disease outbreaks. I think it's also important to recognize that by definition, most refugees, forcibly displaced populations, and conflict displaced populations fit this definition even outside of pandemic conditions. Also, it's important to note that stigma encompasses multiple statuses and characteristics. Therefore, it's often thought of as broader, yet encompassing direct discrimination. So stigma can aggravate disease processes. It can add numerous socioeconomic, psychosocial, and health burdens on people who hold these marginalized identities. It can lead to things like reduced access to education, exposure to psychosocial stressors, and like we're discussing today, challenges in accessing and receiving health care. It's important to think about stigma as more than just a negative outcome of certain diseases or certain conditions. It's actually an illness in and of itself, and it's comorbid with respect to its marked physical conditions. When disease morbidity and mortality are low, but the condition is really stigmatized, the burden of stigma may actually exceed the burden of disease and its impact on social, emotional, and work functioning. So the us versus them flavor of fear-mongering is actually really common in epidemics because people have this tendency out of fear to shift the blame onto others when we know very well that this does nothing to keep people safe. So we know from previous epidemics, including Ebola and H1N1 influenza, that the indirect health effects of stigma actually sometimes exceed the death and morbidity caused by the disease. Historically, we've seen how stigma plays a role in these epidemics. For example, in HIV/AIDS and Ebola virus disease or EVD, stigma contributed to a lot of lack of access and quality of life issues, isolation, physical violence. It's important to note that stigma is most often coupled with infections that are believed to originate in the global South. So pandemics that originated in areas populated mostly by people of color get the most scrutiny and stigma attached to them. So for example, there was less stigma associated with mad cow disease, but SARS and Ebola were stigmatized. As we all know, COVID-19 is a respiratory disease pandemic, but it's also really a pandemic of stigma globally. So I think it's important to track the trajectory of COVID-19 stigma a little bit. So it started with, blaming Chinese and East Asian populations. It expanded beyond that to really blaming migrants as a whole, I would say. There are two major stigma dimensions to the COVID-19 pandemic that impact humanitarian contexts, I would say. So stigma regarding the origin of the disease itself, which has led to this ultimate placing blame on migrants. So there's this cross-cutting dimension of all refugees and displaced populations being stigmatized in some ways or blamed for moving the disease from place to place. And that's largely because political leaders have misappropriated the COVID-19 pandemic to reinforce discrimination and double down on border policies and conflate public health restrictions with anti-immigrant rhetoric. Second, there's this within group dimension of stigma. So it's because stigma is multiplicative and intersectional, the added stigma of COVID-19 places an undue burden on those already stigmatized within the humanitarian population. So you have women and girls, the elderly, the disabled, those who need treatment for chronic diseases, and then you have the added COVID-19 stigma on top of those dimensions. An important thing that's also arisen because of this response being thought of from moving from outside forces to inside forces and back and forth, there's a lot of blame being placed on humanitarian aid workers for bringing in the disease, and there's a dimension of stigma there as well that needs to be addressed in the response. So basically, I think stigma is it's complicated, but at the same time, we've seen a clear progression of COVID-19 stigma throughout this pandemic, and migrants are really disproportionately targeted and bearing the burden of stigma that we see today.
Thank you, Goleen. I wonder if you can pursue a little bit further ways in which the proliferation of stigma and the trends that we're seeing in the COVID context are similar or different to those that we've seen in past or other health pandemics, be it HIV, Ebola, or others.
Sure. So we know some clear things from HIV and Ebola. So in the context of HIV, stigmatized groups have really included injection drug users, sex workers, men who have sex with men. Stigmatizing attitudes and behaviors included blaming patients, refusal of care, irrational and inappropriate fear of contagion directed towards these populations. These things not only devastated family and social and economic relationships and infrastructures, but they also created huge barriers to access, prevention, and treatment. Stigma in the context of Ebola is equally discerning. It also originates from sort of structural inadequacies, including poverty, lack of education, and political conflict. It led to things like harassment, rejection, abandonment of individuals who had recovered from Ebola. A lot of patients were prevented from returning to their homes and communities. Their properties were destroyed. Also, children were not spared. So a lot of children who were seronegative, they were not taken up for care by families and communities out of fear of contagion. So there's similarities and there's some overlap with these narratives and COVID. So the blame of migrants, both with HIV and Ebola, the categorization of the disease as divine retribution really played out as an aspect of stigma. And we see that in some of the sort of conspiracy angles around COVID. The excuse to use COVID-19 as population control. So that's another sort of conspiracy dimension, but it's thought, COVID-19 is population control, and that just reinforces stigmatized beliefs about who should get it and who shouldn't and who's to blame. The backlash against health workers is common between COVID and Ebola, I would say, because health workers are now, thought of, and humanitarian aid workers are thought of as disproportionately exposed and thus experiencing additional stigma as they try to address the response as well. There are also some unique aspects to COVID-19 stigma, which is really this doubling down restrictions on movement and blaming of migrants. And we saw a little bit of that in Ebola, but I would say that we're seeing more of that than ever with COVID-19. Also, because of the disproportionate burden on those with existing chronic conditions or the vulnerability of women and girls, we're seeing this sort of compound stigma or intersectional stigma for those populations with COVID-19.
I wonder if you can describe a little bit what the implications of all of this is for health-seeking behavior, and what we can expect in the COVID context in that respect.
Sure. So stigma at its core can really drive people to hide the illness to avoid stigmatization, right? It can prevent people from seeking healthcare immediately. It can really discourage them from adopting healthy behaviors, and particularly in the humanitarian context, necessary secondary morbidities because people aren't receiving services and are afraid to receive any care. So I think also it's really important to think about that stigma itself is a barrier against healthcare seeking. So it's about creating a community context in which people are free and willing to seek care. And if they feel stigmatized based on their status or do not want to be found out that, for example, they have COVID and they delay seeking care, that's worse for the COVID pandemic down the line. That's also worse for community solidarity. So whatever we can do to enable care-seeking behavior is one of the ultimate solutions. Also, the diversion of resources, disruption to medical supply chains, health facility shortages of healthcare workers, these things that can all overwhelm the system do not help this process at all. We need to really ensure that effective communication and public trust are sort of integral to helping people overcome those barriers. A lot of this needs to be established from the onset. It's hard to sort of intervene down the line when this trust with the systems has been broken, so it's really important that clear information is given to communities, trust is maintained, things like that, because stigma at its core is a barrier to healthcare seeking behaviors and structures that provide healthcare in those communities.
Yeah. Goleen, I want to try to turn our attention a little bit to some of the political dynamics that drive stigma, and particularly thinking in terms of pre-existing stigma. And stigmatization that isn't necessarily associated with the health pandemic per se, but for example, stigmatization of individuals who are perceived to be affiliated with an armed actor, or are stigmatized as a social group on ethnic, religious, or other grounds. How does that play out in the current context? And I guess, you know, one concern is that it simply exacerbates the pre-existing stigma, but also a concern that a health pandemic like COVID could mean that those situations then tip that kind of stigmatization into overt violence against those population groups. What are your observations in that regard?
So I agree with your assessment largely. Like it can sort of go in two directions. So on one hand, with COVID, it's helped people realize that your health is only as good as your neighbor's. So everybody's sort of on an equal playing field, right? But that doesn't mean in terms of being able to get the virus and transmit the virus, it's all sort of equal if you think about it in that way. On the other hand, COVID has brought to the surface existing entrenched inequalities along so many dimensions, including those who are politically vulnerable, those who are already susceptible to being disenfranchised. I mean, in the US, you see these disproportionate rates among racial and ethnic minorities or even migrants compared to non-Hispanic white populations. Globally, all the things that you pointed to are at risk of sort of, if these populations, if overt efforts are not made to ensure equal treatment in care delivery to all folks seeking care and really communicate, it's not just that the structure exists to provide that, it's that people have enough trust in the system to go and seek care. The problem is, because of these entrenched inequities, like a lot of people don't trust in the system, and the humanitarian space contributes to that a little bit. And we know that, you know, the space is really working to change, but historically it's run by the global north and this sort of like savior mentality and things like that. And so I think that really elevating community voices, making sure groups are represented, making sure that people actually trust those who are providing care and they're involved in the provision of their care, can fight some of that tendency, which could easily, with COVID, really exacerbate the existing inequalities.
Right, thank you, Goleen. Goleen, we'll come back to you with more questions, I'm sure. For now, I want to turn to Irene Scott. Hello, Irene. So Irene is project director at Internews. Thank you. specializing in connecting communities affected by crisis with trustworthy and actionable information, and building systems that allow them to engage with first responders and to play an active role in the decisions that affect their recovery. Irene comes with loads of experience in the Pacific, South Sudan, Bangladesh, and Europe, managing community engagement and feedback mechanisms, risk communication, language, comprehension research, humanitarian radio, and rumor analysis. Irene, thank you for joining us. Let me turn over to you and invite you to share with us your initial remarks.
Sure, thanks so much for having me. So I mean, as we've already heard there, COVID has definitely highlighted some existing inequalities that we have present in our communities right around the world. And I would say social media has really just been the megaphone for these inequalities. The project I'm working on at the moment for Internews is monitoring social media in 9 languages across Asia. So a lot of the examples I'll give, you'll find are from Southeast or South Asian countries. It's a very mixed environment that we're monitoring. It's not a traditionally humanitarian environment, but I think there are definitely a lot of learnings that carry over to the way that rumors move through humanitarian crises as well. Some of the examples we're seeing around stigma and rumors, you know, for example, in India, we're seeing migrants from Gulf states being stigmatized, both in media reporting and online in social media. Similar thing that is also happening in Bangladesh and Nepal. In India, we also see, you know, COVID being used as a fuel to something to fuel existing anti-Muslim sentiment that already was taking quite a stronghold throughout social media. In Vietnam and Cambodia, you know, posts encouraging violence towards foreigners or people that have recovered from COVID-19, you know, preventing them from returning to their homes and their villages, places where they need to go to, you know, get ongoing care. And across Southeast Asia, we're just seeing various minority groups being singled out as more likely to spread COVID-19. And of course, you know, the nature of COVID-19 being seen and reported on as an imported disease has really added to this stigma. The us and them mentality of, you know, we were fine until someone brought this to us. But it's also the language that's being used when talking about the virus, you know, giving it that ethnic stamp, calling it the Wuhan virus or the virus from China. But also the battle terminology that's constantly being used as well, which also flows onto the way that, you know, normal people talk on social media. It's always a war on the virus or a war on COVID-19. People talk about being a wartime president. You know, this kind of battle mentality always divides communities, and it does put them in that fight or flight mode, which doesn't help when it comes to stigma. I mean, definitely some of this prejudice existed before COVID-19, some of it is new. So social media has definitely amplified that conversation and helped it to spread much faster than it usually would. But there are some, you know, other psychological elements that are at play here. You have the concept, for example, when you're talking about rumors of group polarization. So that's when a group begins to uniformly believe one opinion about a topic and therefore influencing other members. You know, you might think about all of your friends like a particular movie, and because all of your friends like the movie, you know, you're more inclined to also like that movie. You're also seeing things like conformity cascades, and that's when, for example, someone accepts a rumor or something that is untrue, other types of mis and disinformation, not necessarily because they believe it, but to conform with group opinion for acceptance or to avoid being ostracized themselves. So it's in a way, you know, stigma being fueled by fear of further stigma within a group. And then, of course, something that you might have heard of before, information cascades, which is where each person that accepts a rumor and shares the rumor adds to its validity. You know, how could 2 million people on social media be wrong? How could that be possible? So people start to accept the information on face value because they've seen it repeated so many times. And I think, you know, this all contributes to the spread of misinformation and the spread of information in this crisis, both positive and negative. And there are definitely things to keep in mind. When we're looking at rumors in this crisis, we're definitely not looking just for fact checking. I think fact checking plays a really important role, of course, and making sure people have access to quality information. But we're also looking at rumors as something that highlights misunderstandings in the community, fears and anxieties, hopes and beliefs. Those information gaps are really important to help us understand our communities, and especially in terms of things like stigma and prejudice, to understand where these ideas come from and to work on where those ideas come from, not purely by telling our communities stop being prejudiced or stop experiencing stigma, but to actually work with media and information influencers to help them understand that sentiment and respond in a really ethical and responsible way.
Thank you, Irene. I want to ask you a little bit more about strategies to counter stigma, but before we go there, I want to ask you a similar question as I asked Goleen about, you know, their stigmatization of certain population groups can result in a variety of phenomena. You know, on one hand, you know, there may be just the sustained and pernicious discrimination and exclusion of certain individuals, for example, from health services or other services. There's also at another end of the spectrum more of a tipping point into overt violence. What are you already observing in the COVID context?
Yeah, I think the challenge with the kind of work that we're doing in terms of looking for rumors and misinformation online is that, of course, you know, quite often they can be used as that early warning mechanism. So they can start to give you an idea of beliefs and feelings in the community that might be moving towards something that is more risky. When we're looking for our posts, we've got, you know, 4 main categories that we're looking for when we're assessing risk in a post. Of course, there's the general category of saying, well, has this post been shared a lot? Is there a lot of engagement? But it's definitely not the only metric that we'd be looking for when we try and determine if the post is actually risky. You know, even a post that you've seen shared just one time could potentially have been shared many more times within private and encrypted platforms. You know, the amount of data that any rumor tracking project at the moment, including our own, is able to access, it's just such a tiny window of what's available out there. You know, I think we've definitely seen, especially in countries like India, where a lot of that misinformation and that prejudice that fuels violence is spread on platforms like WhatsApp. And it's just not possible to be able to gather all of that data. It's private data and it's private for a reason. But it's not actually, you're not actually able to see everything that's happening out there. So we have to almost take everything that we see as serious, because we just don't know how many times it's been shared on other platforms. So when we're, you know, assessing that risk, we look at, does it encourage risky behavior? So some of the examples during COVID-19 would be, for example, people suggesting people should drink bleach and chlorine and douse themselves in chemicals, something that will cause risk to themselves or perhaps their friends and family and their community. Anything that would discourage treatment, something that might add to fears that, for example, hospitals or nurses should not be trusted, that they're not places to go. That's something that definitely we've seen in Sierra Leone being shared on social media, not as part of our project, but the wider Internews footprint, where there was a death at a hospital in Sierra Leone, and very quickly on social media, there was a rallying cry to, you know, really blame the hospital and for the doctors and nurses there to be attacked and a hospital to be, you know, burned down. So social media, of course, was a really effective early warning system to see that those kinds of ideas were emerging. Also presenting a community risk, that's something we look for. Is it stigmatizing a particular group? That might be, for example, you know, foreigners, which is something, or migrants that we've seen quite a lot of in this crisis, or it might be we're seeing increasing evidence in Thailand and Cambodia of LGBTQ communities, for example, now being singled out as being more likely to share or to have COVID-19. And of course, you know, we're also looking for whatever might cause a rush or interruption of essential services. So if there are rumors starting to spread that all of the markets and the access to food and medicine is about to be pulled, something like that could cause such a really quick wave of movement in a population that it could become, you know, quite dangerous really quickly.
Right. So shifting gears a little bit, can you speak about strategies to effectively counter stigmatization? And indeed, you know, does it entail using the same media and same means through which stigma itself is propagated?
Yeah, I think that's a really good question. And I think the answer when it comes to trying to understand what your community is feeling and trying to address feelings, whether they be prejudicial or not, is that you always need to work with whatever communication systems your audience already uses. But more than one is always better. So for example, you know, in our project, we're definitely seeing rumors as a really key form of community feedback. So we're using them to take the pulse of the community. You know, there are early warning system, as I said before, they're highlighting prejudice, information gaps, broader societal issues that might be at play. And once you have that picture and that understanding of the community, and you're looking at this information as a descriptor of how your community is really feeling, what we've found is, you know, the best way to address it is to make sure that you're starting a conversation with your community, and using the languages and channels, of course, that they prefer. Some of the communication that's happened in this response, and also in, you know, health crises before this, Ebola is another really good example. You see quite a lot of top-down communication, where a good example from this response would be wear a face mask. And the problem with that is it seems like a very simple piece of information, but even the most simple piece of information has a litany of questions that could come after. How do I wear my face mask? Do I need to wear it all the time? Can I touch the face mask? What type of face mask? Where do I buy a face mask if there isn't one in my community? You know, so just by giving that one piece of advice that of course is given in a very well-meaning way, to give their community a way to protect themselves, it needs to be an open discussion, because when people feel listened to and they feel that, especially those in authority and those that they trust, are listening and responding to their actual needs and concerns and not their perceived needs and concerns, then of course they're more open to hearing what else has to be said. You know, they feel like they're part of the party, you know, as it were. So, and I think the challenge is, as well, when it comes to rumors and to stigma, is that most of the people sharing this information do not know that they're sharing a rumor, and wouldn't necessarily know that they're sharing something that might cause or increase prejudice or stigma towards a particular group. You know, most people don't like to think that they're that person. It's just not the way that we're wired. And that's why, of course, as well, of course, when you're looking for rumors online, you can't just search for rumors, you know, COVID plus rumors, and then, you know, we have all the data. It's often about poking between messages. You know, the most successful rumors that are out there often have a kernel of truth, and they often come from someone that you trust. So it's about looking between that information and trying to see how we can address the rumor and how we can use the platforms that they're already using, and actually engage with that discussion, rather than seeing some of the suggestions, some of the conspiracy theories, some of the rumors that are spread around this as ridiculous. Actually engaging and having that discussion and being open to have that discussion.
Okay, excellent. I already see the shape of some recommendations for the humanitarian response starting to come out, and I want to come back to both you and Goleen to pursue that a little bit further. For now, let's move on to Marion Staunton of HelpAge. Marion is the Humanitarian Inclusion and MHPSS Manager at HelpAge. She has been with, within the humanitarian team based in London. Since joining, she has provided frontline support to HelpAge international response, including in Indonesia, Mozambique, Malawi, and working closely with HelpAge country offices and partner organizations to ensure inclusive programming. Marion has over 12 years experience in the humanitarian and development sectors globally. Marion, can I turn over to you and invite you to share with us your initial remarks?
Thank you very much, Jenny. Good morning and good afternoon to everybody. Thank you very much for this opportunity to take part in this webinar. In relation to COVID-19 and older people, the evidence is clear that people in older age are among those most at risk of complications from COVID-19. However, the fact is that older people and people with disabilities in humanitarian settings, and maybe indeed in general, are already stereotyped, labelled and discriminated against. They face a multitude of barriers when it comes to accessing humanitarian services during a crisis. And indeed, this barrier starts in itself with the data collection. where older people seem to become invisible, are not included, are not disaggregated in relation to age and disability. Older people have, in humanitarian settings indeed, and also people with disabilities, been ignored or made visible or are invisible by organizations and governments. And stigma towards older people, and indeed the aging process, is what I would describe fairly worldwide and not solely within the humanitarian setting. Now, with COVID, certainly the narrative at the start portrayed it as a disease of older people. And that was even in the case here in the UK, where it's very much framed as simply a flu and simply an older person's problem. This, in many ways, has really compounded the stigma and the ageism that already exists. Many older people, as I said before, they're not included in data collection. There is a big barrier to information, access to information. Now, I do think it's improving, but initially having information that's accessible and inclusive for older people and people with disabilities who have different communication needs. Also, with stigma and older people and people with disability, there seems to be a lack of recognition of the diverse roles that they play. And what we have found in HelpAge in our needs assessments in relation to different humanitarian settings is they have many different roles, and in particular, roles as carers of others, whether it's older adults, children, and so on. There is a way that older people are framed that takes away their resilience and their capability and does not recognize what they can actually contribute to a response. Their voice in many ways is sometimes missing when it comes to responding to a crisis, preparing, and so on. In relation to what we can do, well, we can start by listening. We can start by listening to older people. We can ensure that they have access to information. We can engage and consult older people and people with disabilities in relation to the response, in relation to what they feel is the best way for them to participate. We can, language I think is very important in relation to the language that's used in the messaging around COVID-19. In many cases, it can be ageist and stereotyping and can increase stigma. It needs to be clear and simple so that older people and people with disabilities can understand what is being said. And we need to provide opportunities for older people and people with disabilities to be part of a response. And hopefully that we will be able to talk a little bit more about this as we go on.
Yeah,
thank you.
Marion, thank you for that. I mean, it's really clear in how you're describing it, you know, how a society views and treats the elderly and the disabled is in fact a reflection of the values and norms of humanity in that society as a whole. Can you speak a little bit further about how to overcome the stereotypes and perceptions of the roles of the elderly and disabled individuals as part of HelpAge's work in humanitarian response?
Yes, indeed. Well, what we would start with, of course, is that they are included and the information within any kind of assessment is disaggregated on age and disability and gender. That would be the first step. And the next step is to engage and consult older people and people with disabilities in relation to not only their needs, but in relation to their response and how they can work with organizations. For us, that is done through many different modalities. In some places, there are particular organizations that work with people who have certain disabilities, and also older persons associations. The next thing is about, as I said earlier, accessible communication. Whatever information, how you're sharing it is very important, and it needs to be accessible. Some of the discussion that I've had with colleagues here and abroad in relation to supporting older peoples, a lot of it, because of COVID and the measurements that have been taken in place, have been through the phone, which is very good in countries like, if you take, for example, Jordan, where the HelpAge team did an assessment and found that the older people they were working with and supporting, 80% of them had access to a phone. But in other countries and contexts, that's not going to be suitable. So we need to find out what is their preferred communication method and how can we tap into that. Basically, we need to give older people and people with a disability a voice and recognize their capabilities and their capacities.
So I think from how you're speaking about it, it's clear that that the humanitarian community needs a shift in mindset to put the effort into disaggregated data, more listening, less top-down communication, and so on. What about societies as a whole? And is there a public messaging component, or investment in shaping societal norms, through engagement with local civil society, that should be part of this effort?
Well, yes, of course there is, and that's part of our work in relation to advocacy and raising the voice of older people and making those connections between all that are involved in the society. But from the humanitarian perspective, we're thinking of it in a very much, programmatic, how we respond in relation to our projects, how we adapt what we are doing. There is, sometimes you do wonder where stigma ends and ageism begins. And that's a whole other area that needs to be unpacked. But yes, indeed, within what we do in relation to other organizations, we have a very strong advocacy component that tries to bring about or bring that thinking within society of how it is we think about older people. Older people, as we say, are us. Older people, as we grow older, our lives do not become disposable. And that is what we try to work on.
Okay, thank you, Marion. I wonder if we can turn now to our fourth and final panelist, last but not least, Dr. Ghazzy. Can we get his bio up there, Liv? Hello, Dr. Ghazzy Debs. Good to see you. Ghazzy is a protection project manager with the Syrian American Medical Society, or SAMS, in Turkey. Originally from Aleppo, Dr. Ghazzy has spent many years working in the humanitarian sector in Syria before moving to Turkey. He is the co-founder and former CEO of Shafak, a Syrian humanitarian organization. Can I turn directly over to you, Ghazzy, and invite you to share with us your initial remarks?
Yeah, for sure. Thank you, Jenny. Hi, everybody. It's my pleasure to be with you in this webinar, and thanks for the opportunity. Of course, I will talk about the impact of this social stigma associated by COVID-19, especially on one of the vulnerable and neglected and sometimes marginalized categories of population, which are the IDPs and refugees. IDPs, which means the internally displaced persons. For those two categories of population, they are already suffering from multi-layers of stigma. As you know, they're already living under the stigma of being displaced, Those people are now foreigners coming to our city or our village, and they are sharing our stocks and the economy. This is for the internally even. So we can imagine also when those people cross the borders and go to another countries and to be refugees, already we have a lot of challenges and for this kind of stigma for those refugees. Already those two categories, the IDPs and also the refugees, are suffering from a lot of loss of access to the services available in the country. Already there are a lot of backlashes and a lot of stereotypes, like xenophobia against them. Always they are suffering against. Sometimes they are already living under war, like what's going on in Syria nowadays. So you can imagine what kinds of impacts this stigma of COVID-19 will do as a multiplied stigma and multi-layers of stigma. For that, we really need to highlight these kind of issues and to go deeply in these two categories, and to, of course, to be a kind of effective and practical recommendations, just how to adjust our approaches to work as humanitarian NGOs, not only health organizations like SANS, but all humanitarian NGOs, but also all stakeholders in the civil society itself. Because, when you speak about stigma associated with, for example, gender-based violence, disabilities, and so on, so it's very much impacting the person and the families. But when you speak now here for stigma related or associated by COVID-19, so the impact will be more spreading. It's not only for the community, not only for all the country, but it's for a global issue. So really, it's very important to highlight those very important two categories, especially that speaking about that, this outbreak exposed that how much we have gaps in social cohesion. Yeah. And we are working a lot of overloading programs and operations. But when we look to social cohesion, unfortunately, the funding for this kind of projects, the real implementation for social cohesion, it's very weak, and there are a lot of gaps. Protection monitoring, gender mainstreaming, all kinds of how to really look for these kind of aspects and principles in our everyday work and everyday lives. If we were ready and we have full social cohesion and smooth social cohesion and full integration for all categories, I think this kind of impact of stigma will be much more lessened. Over to you, Jeannie.
Thank you for that. What have you observed in terms of more specific consequences of COVID for the displaced population in Turkey and Syria?
Yeah, for sure, Jenny, when you go deeply in, for example, our projects as a humanitarian NGO, and to see how really this will impact your work and also the access for those categories to your services, it is very important to say that this kind of challenges a lot of time made you to reprogram your work and to start to try to find more new innovative ideas, how to reach those people and how to really make those people for to have full opportunities and the same access to every and all kinds of services that you are providing for those persons. So, for example, inside Syria, when we started to work, it was until now in areas where we are working, there is no positive cases, but still we don't know how much numbers we have of those cases are living secretly and are hiding here and there. So this kind of time bombing anytime can explode, and you will have suddenly a change in this. So those people really are suffering, and we can identify those people. This is, for example, we have some cases when they have been surveyed for the triage space, in the triage spaces, they run away when they saw, for example, their temperature high, for example. We have some cases we still looking for them, and especially in areas inside Syria where we are working, there is absence of rule of law. So there is kind of a very weak and destroyed health system. So those people, it very easily can be hiding here or there, or can be neglected by all kinds of services and all humanitarian. If we cross the borders and we come to Turkey, for example, to working with those refugees, you know, those people are have a lot of barriers for language, have a lot of barriers for the culture. Sometimes, you know, the services that have been provided by the government is not reached to those people. They don't know even sometimes the resolutions, the decisions that are made by the government. This make a lot of, and you know, you can imagine those refugees are already have restrictions for movements. They need always, you know, travel permissions when they want to move. They have a lot of restrictions for the access to even the available services by the government and by even NGOs. But always there are barriers and there are restrictions. So you can imagine what's happened for those people when this outbreak started, and this increased both, you know, their suffering and also the position. Theoretically, let's say, when you have this kind of global outbreak, it's the most time that people start to sympathy with each other, start to be somehow looking to each other. Unfortunately, for the refugees and for the IDPs, it's a controversy. On the contrary, people started to be more violent against them. It started to depend more on, you know, the horrific and all kinds of media abusing this kind of those people. Maybe they have, you know, transmission the disease, and they have a lot of, you know, low income and low state of health. So this made a kind of reverse. You see a lot of solidarity in other countries for the host communities on each others, but when we look to the refugees and IDPs, it came back again with more violence against them, more exclusion against them, unfortunately. Over to you, Jenny.
So I want to go a little bit further on the dynamics that you described. You said if an individual at a health center is found to have a high temperature, they run away, they avoid treatment. Is that because they fear the risk of violence and exclusion that comes from being seen as someone who has been infected by COVID? Do they fear perhaps being quarantined and separated from their families? What is driving the health-seeking or health-avoiding behavior in that context?
Yeah, you know, for example, in Syrian context, at the beginning, we tried a lot and we spent a lot of efforts how to make this kind of precautions and make people to make it more serious approach for really prevent this kind of outbreak. But afterwards, when we have a lot of, you know, horrific cases on media and a lot of this stereotype coming from social media, and sometimes even the regulations that came from local authorities, regulations, and sometimes it's not intended, but from NGOs themselves, sometimes when they share some advices, they make it in more pessimistic and very, you know, horrific way. This makes people start to be very terrified from this, and they start even to avoid coming to the centers, health facilities, even if they are suffering from any kind of you know, symptoms. They try to use some alternative medications. They try to hide their secrets. But if they were obliged to come to have vaccinations for their children, for example, or any kind of services, even for the PSCs, when you have nowadays, most of the health facilities have at least a triage space. When they have these questions, they try always to hide even, and it's very easy to identify that those people are trying to hide symptoms and even, but for them, because, you know, inside Syria, there is no rule of law, so they don't know what will be the sequences. They don't know what will be the position from the local authorities, from the armed groups there, from the people around them. If they are IDP, internally displaced person, living in a camp, for example, maybe they will feel very terrified that they will be kicked out of the camp, for example, because of this kind of things. When you go to the other context, for Turkey, for example, due to, as I told you, that already those refugees are living under stigma due to state of refuge, they already always hesitate in accessing services. and they have difficulties in these services. But if now they start to have these symptoms, they will be fear about that the quarantine, to be separated from their families, to be repositioned to inside Syria, for example. And because, you know, all the time, of course, no cases happen and nobody will do this, but, you know, this kind of stereotype and kind of prejudgment that because it's very strict rules against the refugees and any kind of mistakes, the refugees will be threatened to go to Syria back. And so they can imagine what they have, a lot of fears, how to be. And even for when you see this kind of in media, the isolation units, always the scenes of those people and what's going on for those people in the isolation is really, it's very much, you know, make a lot of bad stereotypes for people not to go. And you have also to add to this that already in some societies and some cultures like Syria, people have stigma, fear for stigma of diseases in general. Stigma of to being a patient of cancer, for example. Stigma of being, even for non-communicable diseases. So you can imagine what is going on now for stigma associated by COVID-19.
Yeah. So I want to go a little bit further to look at some practical strategies as part of a humanitarian response in light of the dynamics that you were talking about. And of course, one of the challenges is the physical proximity and interaction by humanitarian personnel, and including medical personnel, with vulnerable people, infected or not. And, you know, the risks that we are all trying to figure out, how do we work, you know, how do we manage remotely, how do we consult with people when we're engaging remotely, and so on. How is SAMS handling this, and what are some examples of good practice?
Yeah, for sure. It's very important because when this outbreak started to have more and more numbers and impact, you will stay in, or you will find yourself in a dilemma. I have my duties and I have to continue my services and to continue providing all kinds of services, and especially related to the new outbreak. But at the same time, I need to protect myself and to protect my staff, protect my families and families of my staff. So by this way, you need to have a balanced approach, and to not to be a kind of just driven by the sympathy and to do sometimes harm for the staff or even for the population themselves. Because at the end, it's a kind of general duty and responsibility for everybody, not only something related to personal issues. For that, we sit in SAMS and we establish a kind of a special task force to make a lot of discussions on a daily basis, and to follow the updates and to see what kinds of the most scientific approved recommendations, and also to add more reconceptualization for the context of Syria and context of Turkey, how to put a kind of preparedness and response plan, the trainings for the staff, where we have to continue trainings because some activities have to be continued. What are the new terms and new conditions, the SOPs for the trainings under COVID time, for example? How to go and make individual case management for some cases, for GBV cases, for, you know, even health cases. We need a lot of protective equipment. We need the social distancing. It's better, physical distancing is better than social distancing, maybe one of the recommendations, because already we are looking for social integration, and then it's kind of very difficult term. So when you really set your rules and your plan, how to continue your services, stop group session, for example. This group session, if you are obliged to conduct it, have to be maximally 5 persons with social or physical distancing and all kinds of precautions. So it's really working well. At the first time, there was some, you know, resistance that how we can go outside the centers, how we can continue our work under these circumstances. But by the time, you will see that it's really working well, but you need the will, and you have to be prepared and equipped by all kinds of resources. And number one, the very important thing, that you need to have a kind of sustainable, trustful relationship with your own beneficiaries before.
Yeah.
If you suddenly appeared and now you came to this new community and you want to help those people, you will not succeed in this, because a very main important milestone that at the cornerstone that you have your reputation, your trustful, sustainable relationship, because under COVID, the most important thing, how to communicate with those people.
Yeah.
And really COVID-19 show how much gaps are in our communication. We are always busy how to make resources of funding, how to plan for the activities, how to implement activity, but always we forget this kind of sense of how we are communicating with our beneficiaries, how we are building a kind of relationship with our, take us back to that. Really, we need to look for the social cohesion and to the integration for all categories in our work in the same surfaces. This will really ease the lives of everybody.
Okay, thank you, Ghazzy. So I want to start to turn to all of our panelists for a round of questions. I want to remind the attendees today to use the question box that you should see on your screen. Type in your questions there. My colleagues are receiving your questions and will direct them to the panelists. While everyone is typing in their questions, I want to come back to Irene. I wonder, Irene, can you give some examples of those who are thinking innovatively about stigma and countering stigma? Are there some examples of good practice that you would like to highlight, and what should we be thinking about going forward?
Yeah, for sure. I think, you know, and I wanted to come a little bit off the back of what had been said by a couple of the other speakers there, that there were quite a lot of mentions of media being quite a problem in this crisis, and social media also being quite a problem in this crisis. And you know, that's indisputable. That's of course true. But I think there are a few ways to approach that. And I think one of those is the humanitarian community looking at media with a different lens, and to, you know, to see that it is of course sometimes part of the problem, but it's also part of the solution here. You have journalists all around the world at the moment that have perhaps the biggest story of their career, depending on where they're working. You have journalists that are all suddenly expected to be health and science reporters overnight. Very complex areas of journalism that everyone is expected now to be an expert in. And I think for humanitarians, quite often they look to the media as a place to send a press release, to have a spokesperson on occasionally, perhaps to have a radio drama. They don't necessarily see them as a communication partner in this. And I think that they really can be seen as that legitimate partner with an ongoing long-term relationship, you know, where you engage outside of the story as well and help them to understand our world and understand prejudice in a more significant way, and how that they can actually work with it as well. And I think, you know, building the skills of the journalists is huge, and connecting them with the latest information in the right language. And I think, you know, that is one of the biggest challenges in this crisis, is that, you know, we talk about having an infodemic as part of this crisis, of having so much information. And, you know, that label itself has come from an extraordinarily privileged position. We don't have an infodemic, we have an English infodemic. You know, the journalists that we're working with across South Asia and Southeast Asia can't access all of the scientific information that's being released at the moment unless they speak English, and unless they speak English to a degree that they can understand complex scientific contexts, complex and health concepts. And I think that's something that we really need to look at, is making sure that we do connect our journalists and inform them, and take them along this journey with us, because we can't expect them to suddenly understand our world and suddenly understand how stigma and prejudice plays into their reporting, and how sometimes they are themselves contributing to those situations. You know, we need to take them on the ride. And I think some of the best organizations that are doing that, you know, you see BBC Media Action doing some wonderful work. There are lots of wonderful, you know, media development organizations around the world. I would like to think Internews is one of them, where, you know, media is seen as a real partner in humanitarian work and not as just a place to make announcements.
Yeah, Thank you for that, Irene. Really specific and good example. Goleen, I want to come back to you. I wondered how you would describe the critical success factors for countering stigma. What would you look for as sort of the core elements of an effective strategy?
So I think that people have touched on this as well, and I touched on it a little bit earlier, but at the foundation, pandemic control relies on community engagement and trust. So the media plays a role in this, service delivery providers play a role in this, but you have to elevate these communities that are the most vulnerable to being involved in the response as a critical aspect of stigma mitigation strategies. If they don't feel like they're involved in the response, there's not going to be that element of trust, and it's going to lead to further stigmatization and distrust of the system as a whole. To build on some issues that Dr. Ghazzy brought up as well, I think in terms of like strategies in the healthcare sector, you want to reduce crowding and time spent in health facilities. So you want to utilize outreach workers as much as possible. You want to use appointment slots, but it has to be like, if you're presenting a schedule and a system, then it's sort of, you have to adhere to it as much as possible. And again, like any of these things that I mentioned, really come down to community engagement and trust. And I can't reiterate that enough, because if you don't have the trust of the community and you don't have community involvement, then you're just marginalizing and disenfranchising people further.
Yeah. One final question before we turn to questions coming in from attendees is, are there particular contexts in the world now where we should be especially concerned about stigmatization in COVID? And you know, that concern may be born out of the sheer sort of pervasiveness or severity of a stigmatization trend, and the degree to which it's impacting people's ability to gain assistance or access to healthcare, or just exacerbating their suffering. What are the contexts we should be concerned about now?
Is it for me?
Anyone.
Okay.
But we can start with you, Goleen, if you like.
Sure. I mean, I want to reiterate what Irene brought up about the issues in India right now and the pre-existing things going on with Muslim populations there. I think it's really not elevated enough or discussed enough, and is just likely to continue to get worse, and it's terrifying. I think that Cox's Bazar, I mean, it's hard to sort of elevate any of these places. There's also refugee situations that sort of have been long forgotten, that there's no ventilator in the country as a whole. And so how do you, strategies for like these sort of forgotten groups, like there's a lot of need in the Syrian crisis, but what about issues going on in sort of Eastern Africa and these really remote displacement areas and camps, and sort of what's the strategy there when there's no soap and things like that. So I think a lot about sort of the spectrum. So the crises that have really moved towards development and how stigma manifests there, and the humanitarian situations that sort of have been long forgotten and are less addressed, and how do you address this there? So yeah.
Thank you, Goleen. Irene, did you have thoughts on that question?
Yeah, I think, you know, what I wanted to add on that question is that, of course, you know, the humanitarian environment's our biggest concern. And I think the challenge with this being a pandemic is that you do have a lot of people living in first world or however, you know, developed countries that are suddenly affected by a crisis or by a health situation that they wouldn't have been affected by before. You know, they're suddenly seeing that it's affecting their economy, it's affecting their daily lifestyle, it's affecting their ability to see loved ones, friends and family. And we're seeing the way that governments can react if they want to these situations to protect their populations. And I think the challenge is that, you know, because so much of the media does exist in these environments, it's very easy for it to forget that the impact where we live is one thing, but the impact in a humanitarian environment, in a refugee camp, in a conflict is always going to be so much worse. There's just going to be less and less space in the media for them to actually cover those effects and for people to have the bandwidth to have empathy for that.
Yeah, absolutely. Let me ask Ghazzy and Marion, any thoughts on that question? Particular context of concern to you?
Yeah. Sorry, Dr. Ghazzy,
No,
please go ahead.
No, go away, please.
I would agree with what Irene and Dr. Goleen said in relation to particular contexts. I'd also put into that care homes. Actually, you know, we don't have to look far in relation to concerns about care homes, even if you look here within the UK, but also care homes and what they mean in different countries and different contexts. I'd also like to mention Venezuela and issues and problems that are emerging in relation to COVID that are being highlighted from South America. Definitely in other contexts, especially for older people, people with disabilities, they do have a lack of hygiene facilities, even basic water and that. And other issues that are going on that are long forgotten, but they are still there. That is where my concern would be.
Thank you, Marion. Ghazzy?
Yeah, for sure. I just want to echo again what the colleague said, that you can imagine that there are some contexts where you don't have government responsible. You don't have government accountable for the community themselves. Sometimes the government is making violations for the people themselves. So in these contexts, like Syria, like Yemen, and other contexts, that those people are really missed. For example, when you have kind of a new trend for a kind of stigma for one of those populations or communities, always the government start to do a lot of projects in media and conferences and make advocacy in a very high level. But if you look to those countries where you don't have any accountable governments or any kind of rule of laws, really those people are very missed and very marginalized, and this kind of context is much more and of course, apart from geographical context, I think also we need to look that nowadays globally, let's say the vulnerability groups, the elderly people, the persons with disabilities, and of course the survivors of GBV, gender-based violence, always make a kind of a challenge in all contexts of the world.
Thank you for that. With that, let me check with my colleague Anna to see what kind of questions are coming in from today's attendees. Anna?
Yes, hi everyone. I'm so happy to see how many people joined us for this conversation today. We do have a number of questions that came in, not all of them extremely stigma focused, but the first one that I think is really important to look at is, the issue that stigma is a multi-sectoral, multi-faceted issue that can't be addressed by one sector, by one group, not through just the media, not through just humanitarian organizations. So the question is, how can we work collectively to address this issue? And I think I would like to see if Dr. Ghazzy would like to take a stab at that question.
Yeah, for sure. I think this kind of question is very important question and effective for the future recommendations. Because, nowadays through the experience of humanitarian workers and the humanitarian field, for example, we make a lot of thematic theoretical articles and working on, some we call it intersector issues and cross-cutting issues. I think really we need now to add stigma to be one of those intersector issues and cross-cutting issues for all aspects, not only for humanitarian NGOs or actors, not only for civilization actors, for all components of civil society. As my colleague said, all kinds of for journalists, the local people, the community-based leaders of the societies. So by this way, really, it's the only most effective way how to mitigate stigma and how to work together. Because, you know, at the end, you have to be prepared before. It's very difficult to say now, after COVID-19, let's now find a solution for stigma. We need to be prepared before. We need to be unified before. We need to be living under really social cohesion in all contexts, and to looking for inclusion for all those vulnerable categories in our responses. And this exactly need the cooperation and the work for all of the components of civil society, for sure.
Thank you so much. Does anyone else want to take a stab at that question?
I just want to extend it a little bit more and say that we've been talking about durable solutions for a long time, and this really, and the sort of intersection of COVID with economic issues really highlights how this has to be a multi-sectoral approach, because you can't ignore sort of the livelihoods issues or the education issues that are going on in conjunction with COVID in the global north and the global south, anywhere. So it's all happening simultaneously. It's all affecting people's lives together. And so unless we have actual durable solutions to sort of engage and address these issues from before the start of the pandemic, it's really hard to do it on the back end. So as we move forward, we sort of need to have those systems in line.
Thank you so much. That was from James Chianien in South Sudan. So thank you for the question. The next question is directed at Irene, and it's from Michelle Rice. So the question is kind of about you know, your experience with media when you can't really trust the media itself. So in certain contexts like the Palestinian territories, or you could even say, you know, certain media outlets in our country now. So very many contexts where we distrust the media, and so the media is the problem. But also in situations where there's a distrust of media being fostered by government. There's kind of this fake news, you know, rhetoric going around. So I guess it's a multifaceted question. One being like, what about when media is the problem? How do you kind of counter or you know, build that trust with the communities that you need to have then? And then what about when, you know, media is not the problem, but the kind of government rhetoric around the media is the problem? So over to you.
Yeah, that's a big question. I think the first thing I would say is, you know, media is certainly not the solution in every environment. You know, I think that's a perfect example of some environments where necessarily using the media as your way of communicating with the community is not necessarily going to be successful. I think where we start from at Internews is trying to look at the community and where they go for trusted information already. And that might not be the media. It might be the media. It very much might be. And if it is, then great. Work with those systems that they already use, that they already go to, that they already trust. If they don't trust the media, then where else do they trust? Are they trusting information from religious leaders? Great. Let's focus our efforts towards working with religious leaders to make sure that they have the latest information and are informed and are able to, you know, do their community the justice of and the service of giving them quality information. I think this crisis has also definitely seen a number of world leaders that are not necessarily also giving trusted information. You know, I think there were allusions there to Donald Trump, of course, but you know, there are other media, there are other, you know, politicians in other parts of the world that are also part of the misinformation and part of the spreading of rumors in this crisis. And I think in that time, if you do have a trusted media, that's also where the media needs to make a really solid decision for themselves about when they do and when they don't repeat statements from world leaders that might be divisive, might be dangerous, might lead to risky behavior, and especially behavior that might prevent people from seeking treatment or testing with COVID-19. You know, I think it's really challenging for media in this time that they do feel that they need to be on that 24/7 news cycle, so they need to report absolutely everything that anyone in power ever says. But I think they also need to remember that they do have this role of informing their community with quality information, and that doesn't mean broadcasting things when they can be dangerous. So I'm not sure if that answers your question, but I definitely would agree that sometimes media most certainly is not the answer and is not the way to go. But that's why it's really important to understand how your community communicates, where they get their trusted information, and to use those outlets that they're already using. You know, so for example, in the project that we're doing in across Asia at the moment, media is certainly one way that we're using to work with media, to inform media, to be able to translate you know, the latest scientific research in a way that they can understand and absorb and then deliver to their audience. But we're also working with information influencers, and you know, that might be a community leader, that might be that person online that put out a really great rap song last month that everyone follows and trusts and listens to, perhaps of a younger generation that you might not have taken seriously before this crisis, but now you realize that actually if they've got the ear of so many people, why don't we work with them to make sure they're also doing their bit to make sure that the information they're giving is quality, that it's actionable, and that's something practical that the community can act on, so they feel less helpless in this situation.
Thank you. That was really helpful. I think we have time for one more question. For those of you that we weren't able to get to your questions, we'll do our best to follow up after the webinar. So the last question is kind of a very practical question. I mean, this was raised throughout the conversation today that stigma can really expose people to a lot of stress, you know, especially marginalized communities. So the question is about what we can actually do for those people, you know, who need support in managing the stress of stigma in this crisis. Marion, would you like to give that one a try?
Sure, thank you. Yes, indeed, there is a lot of talk that, you know, many aspects of COVID-19 will have a great impact on all affected, including ourselves in many ways, but others more so on our mental health and psychosocial well-being. And indeed, this has been kind of highlighted or flagged as a particular issue, may indeed for older people and people with disabilities, because of the stigma that is involved and because of the stigma that they already experience. In relation to what we're doing, what our network members are doing is, as Dr. Ghazzy mentioned earlier, is we're trying to adapt our response within this COVID-19 reality. And it has been a very big wake-up call in relation to how we work and how important that physical contact, that meeting with older people, that encouraging older people who are isolated to come together to provide support for each other, and how now we're challenged, but learning from others how to overcome this at this particular point in time. It's also a challenge because, you know, we're at different stages with COVID-19 in a way in different parts of the world. So, you know, in certain places it is complete lockdown, and then in other places, I think, for example, like Vietnam, you can go out. So there are a lot of these different challenges. What we try to do is, within some of the work that we're doing, projects that were already happening and that we had to adapt, was, of course, to go through using the telephone support. This worked very well, as I said before, in many countries it does, and in others it's, you know, maybe not as good. I definitely think what Irene said earlier about partnering with the media is absolutely right, and that can be done even in relation to providing, you know, psychosocial support to try and manage stress. Messages can be shared in many different ways. I think I heard from a colleague in Africa about messages coming through on the radio and so on. In another country, they were sending out protection messages or, you know, psychosocial messages via text messages or SMS. Again, I know that there's limitations there in relation to who they will access. So there is a lot of information out there on how we can manage the stress that we'd experience and that people experience in relation to COVID-19 and the stigma that comes with it. It's just a question of trying to get it into a format that's accessible for as many people as possible. Thank you.
Thank you so much. Did anyone else want to comment on that question before we?
Yeah, please, if I may. Just to add to what Marion said, that number one, the key here and the issue here is how to identify those people, because it's a kind of challenge in all contexts and all this kind of different countries and different contexts. Even for those, most of those people are unfortunately living very separately and insecretly. So the key issue, how to identify those people, number one. And then to see, as Marion said, that what are the innovative new reprogramming for our traditional interventions, how to conduct with those people, how to communicate with those people after identification of those cases. There are a lot of working is happening nowadays all over the world, even online sessions for even individuals, online sessions. Somehow start to see some possibility that we need to do group sessions, even online. There was a lot of challenges at the beginning, but then by the time people started to see that it's even much more effective when you have this kind of group sessions online, each one at his home. But at the end, the issue is how to identify those people. For that, going back to the partnering with media, I think media partners are much more equipped, that they have the access to everybody. So I think it's very important, as Irene said, that we really need to work together and not always looking to the media in a kind of doing always mistakes and something like that. Of course, even sometimes media or some agencies are doing some mistakes inintendedly. It's not intendedly, but it's very important to work collectively and sit together and review what we are doing, make lessons learned, and make a kind of recommendation to each other. Media making recommendations for doctors, doctors making for media, and so on. But really, it's a key access through media to those people, number one, and we can send something, let's say, preventive messages, kind of way how to identify those and help the humanitarian, the doctors, how to identify those people and then go and target them with a lot of multiple innovative approaches.
Thank you so much, Dr. Ghazzy. I'm going to hand it back to Jenny for some closing remarks.
Yes, actually, I'm going to work in one more question before we wrap up and close. So it's interesting to me that I think it was Irene who first mentioned the importance of two-way communication. But in fact, we have been speaking mainly in terms of what we communicate to vulnerable people. We have not really spoken about what kind of capacities should be embedded in communities themselves and enabling communities to communicate for themselves what their issues, concerns, priorities are. So I wonder if I can ask you to reflect on that aspect. What does the investment need to look like in order to better support community-held capacities in this crisis? Who would like to go first? I see Ghazzy already ready to jump in. Go ahead.
Sorry. But you know, because your very important question brought to my mind that there is one picture. I don't know if I can present. If somebody make me presenter, it will be a very expressive picture.
Okay. I don't know whether that's going to be possible in our last minute or so. But is it a picture that we can send out with the webinar recording? There we go.
When you look at this picture, if we really were successful in making all components of society, the vulnerable categories, the foreigners, refugees, IDPs, all components of society, to be really 100% purely included in all of our life, I think we will manage to give this kind of opportunity for communication, for self-defense mechanisms for all components of the population in the society. Thank you.
Thank you for that. It's a shift in mindset in the first instance. Irene, Goleen, or Marion, would you like to chime in on that question?
I'll chime in a little bit. I think that because of I'm just going to pull from an example. So absolutely stigma, part of the issue with stigma is it prevents this two-way communication. One example of programming that I think we've seen that has sort of begun to overcome this and continues to try to do so is the work that's being done in the gender-based violence space. And that's because we saw in places, because of COVID-19, a huge increase in gender-based violence. And so there's a lot of successful sort of WhatsApp-based programming that's using the platform as an open line of communication. And this ties into what Irene was saying about the platform earlier, but it can actually serve a really positive purpose in giving communities access and a tool to provide input and keep it open. And I think that the reason that works and has worked in some places in the GBV space is that there was no continuity in services. And so because of that continuity, again, going back to what I've said sort of this whole time, is it maintained the community engagement and trust. And so it maintained both lines of communication, both reaching out to vulnerable people and having people feel comfortable enough and not stigmatized enough in order to speak up when they needed help or expressing what they needed and in what spaces. And other things like, I think, food distribution, there's quite a bit of frustration because there's a desire for local agency and capacity to distribute food in some of these isolated communities, but it's largely sort of an outside endeavor. And so there's spaces where this two-way thing has worked quite well, and other spaces where really there needs to be some innovation in the thought.
Thank you. Marion, did you want to jump in on this? And then we'll let Irene have the last word.
I just want to add to that. I mean, I definitely think in relation to lifting the voice of older people and the communities they're in, we need to think a little bit more innovatively. Let's start by recognizing that they are there, and as I said before, the different roles that they have. One of the ways that in HelpAge, in our development sector that we work through, is older people's associations. It's not the only way, and that's really what I just add at this stage. Thank you.
Thank you. Irene.
Sure. Well, I think all I would add is that definitely understanding how your community communicates is important. And as we've heard, different ages, different groups within a community use different systems. One example, for example, in Thailand, we've known that older users of social media, for example, prefer to use the Line app, and they prefer to use voice recording rather than text. So you might need to adapt to multiple different, two-way communication tools to make sure that you are really accessing every part of your community. And I would say also that you need to also look at how we're engaging with people that are spreading misinformation and who are adding to the prejudice, because we know that stigma isolates, and we know that when we isolate groups that have extreme beliefs, that we often reinforce those beliefs. So that we need to also be open to talking to people that have very different beliefs and beliefs that go completely against the way we might see the world, engage with them and try and bring them into the conversation as well, and not isolate them further as well.
Excellent. On that really excellent last point, I thank all of the panelists for joining us today. Thanks also to everyone who is attending today. The Interaction Protection Working Group will be looking at diving deeper into this topic, certainly driven and informed by the excellent advice and observations shared today. With a view to looking at what needs to be strengthened in the COVID response, and looking at making some recommendations to different actors and integrating some of these innovations and practices into our own programming. So with that, I thank you. If we were all here in person, now is when we would do a big round of applause Thank you to all of our panelists. And with that, we'll see you in the next webinar.
Thank you.
Thank you.
Thank you.
Thanks.